I had been aware of the TIF procedure for some time. As I mentioned earlier, I had been involved in some early anti-reflux procedures in the early 2000s. So rather than jump in as one of the first people on this, I took a step back and I waited. And my interest arose in part because I was asked to write a review article about endoscopic technologies, and I reviewed the data for new surgical techniques, including links and other things, magnetic sphincter augmentation, and then I also looked at some stimulatory devices, and I looked at TIF in great detail. And I was impressed with the evolution of the procedure, the respect for the hiatal hernia, the respect for the anatomy, the fact that it models in many ways what our surgical colleagues have learned and done for some time. And so, we've talked a little bit about the workup. The procedure is really, there's been a lot of device modifications that have facilitated, I think, the procedure in terms of placing the fasteners to kind of create the fundoplication. And it's a 270-degree sort of omega wrap. So we were talking about what's the size. And I think the primary advantage of the TIF is that it seems to achieve many of the benefits of a fundoplication that's done surgically with fewer side effects, particularly that gas bloat and dysphagia that we were talking about. It's a relatively quick procedure, especially if you can do it in the endoscopy unit for patients with less than 2 centimeter hernias. We have been booking them, even though we've only been doing them now for less than a year. We don't find that we really need to book them for more than an hour or a little bit more than that, and that just gives us time to get everything set up. But really, the procedure itself is pretty efficient, we typically go down. We place the esophagus device down, and then the endoscope goes through that to allow us to visualize and perform the procedure with the esophagus device. We place anywhere between 20 and 23 fasteners, 24 fasteners, somewhere in there. And then, the patients are observed overnight, just more precautionary, and we just sort of have them swallow something the next day and make sure they're feeling okay. And they're out usually in a 23-hour stay. The patients, generally, I've been very pleased. I was expecting to get a lot more phone calls after the procedure from patients, with this or that. I really don't hear from them. We give them a very detailed set of instructions about exercise and activity and diet. Usually 3 days of clear liquids, and we move to full liquids for the first 2 weeks. Then we sort of move to a pureed diet, and then sort of for 2 weeks, and then a soft food diet for another 2 weeks until 6 weeks, when patients are able to resume a regular diet. And then there's a graded activity increase, but really avoiding heavy lifting or weights, again, over that usual same 6 weeks. We've been bringing our patients back at about 2 weeks for an office visit, sometimes a telehealth visit. And then usually, kind of towards that, maybe 2 to 3 month period, just to make sure everything is sort of settled in. And I think patients have been very satisfied. I've not really had any major issues at all. In fact, the vast majority of the patients we've done, we don't ever hear from except on the day of their scheduled visits. So I've been very pleased with both the results as well as how well tolerated it is and how time efficient it is in the endoscopy unit as well.